It is my distinct pleasure to welcome Saleem Malik, who will be talking to us about the insular approaches. Saleem and I had the pleasure of overlapping at Vanderbilt, and then he ran off to Texas and has been at Cook Children's ever since. He is the medical director of the Comprehensive Epilepsy Program at the Jane and John Justin Neuroscience Center, and it's a little hard for me to believe this, but he has been doing pediatric epilepsy for 20 years now. He is going to be followed by the illustrious Dan Curry, who was crazy enough to drive in this morning. And he is going to be talking about laser ablation of the hypothalamic hamartomas. He is the director of functional neurosurgery and epilepsy at Texas Children's. He is professor of pediatric neurosurgery at Baylor, and he is the John Dunn Foundation Endowed Chair in Minimally Invasive Surgery. And I would say that Dan and I share a love for the roles of neuromodulation in the pediatric population, and today we get to focus primarily on epilepsy, but maybe one of these days Dan and I can talk about movement disorders. Our last speaker in today's session, I am pleased to introduce my partner at Dell Children's, Omar Iqbal. Omar came to us after finishing his fellowship at CHLA, and he is sort of a unique pediatric neurosurgeon in that even before he did his fellowship at CHLA, he did a fellowship at Great Ormond Street to work with Dockling Pang and the group there. And then he also did a spine fellowship at Shriners in Philly, not Pittsburgh, old stomping grounds. And so that has been really neat to have him join our practice. And he is going to talk to us today about approaches for hemispherectomies. And with that, we'll have Saleem come up.
All right, thank you. So as I was listening to the talk this morning, excellent talks, and I was thinking, this is a little bit of a busy slide, but I was thinking each point on this slide has been elaborated by one of the people my predecessor, people who talk about these things, and I'm like, at least my talk is not by the end of the day, otherwise all my slides would have been redundant. So I've been asked to talk about the insular epilepsy and surgery. It's a very unique place in the brain and kind of challenging area to approach, diagnose seizures as well as the epilepsy surgery. I love this topic. Thank you for letting me talk about this thing. So I wrote that neurologists redeveloped the interest in the insula in early 50s when work of Penfield, Falk, and Jasper, basically, when they started stimulating the insular area with their cortical stimulation in Montreal, they started noticing that symptoms produced by the cortical stimulation were much like a temporal lobe kind of symptoms, like a temporal lobe seizure symptoms. So, and then people started talking later when the temporal lobectomy kind of become a more common thing for epilepsy surgery. People noticed that they started thinking that maybe the insular seizure onset is responsible for some of the failures of the temporal lobectomy. So there came a time when people started thinking about doing the ATL for a seizure and then resecting the insular region as well. But that kind of fall out of the favor for a couple of years or maybe a couple of decades. And I think the part of the reason was the limitation of the scalp EEG and even the subdural electrodes. The way we'll talk about it in a second, but insula is kind of tucked into the brain in such a manner that there was a limitation of scalp EEG. By 1960s, Ian Talahash and Ian Benko in France were doing these experiments with what we now know as stereo EEG, which provided them with an excellent tridimensional view of the resolution of the ictal discharge. The temporal resolution, basically, with their research and with the stereo EEG becoming common, went from seconds to milliseconds in temporal resolution. Same time as we started using the magnetic or electric source imaging and the MagScan, which provided us with a spatial resolution, which moved the imagings like the PET scan and the SPECT scan from centimeters to millimeter. So generally what happens is that with more invention, the doctor's life become easier. They have easy things to accomplish. But I really believe that since we started using these two technologies, the life of epileptologists and the surgeon actually became more hard, in a sense that with these excellent spatial and temporal resolutions came the bigger responsibility on the epileptologist to come up with a hypothesis of epilepsy organization, in a sense to find out, to move from a point where you can make a hypothesis of seizure from lobar to sublobar region. It was not enough for us, or it is not enough for a modern day epileptologist or epilepsy surgeon to be just pointing that this is a frontal lobe seizure or this is a temporal lobe seizure. You have to get into the sublobar region. And I put this O and U and this is the dilemma the modern epileptologist and the surgeon face, is that you have to be careful with O and U stands for over and undersampling. And we'll talk more about it as we move on in my talk. But it's a big, in each individual patient, you have to customize a plan for that patient. And for that, your hypothesis is very important, that you come up with a really good hypothesis where your seizure is coming from. Because though there is an excellent temporal and spatial resolution, at the same time, the stereo EEG has a limitation that it has a very telescopic view. If you are not at the right place, you are going to miss it big. As on the other hand, it's an invasive procedure. You overdo it, you are going to hurt the patient. So it's big responsibility of the epileptologist and the epilepsy team to come up with a plan which is very balanced and appropriate for that patient. So you are not oversampling, you are not undersampling, which both of them can have consequences. So going to Insula, Clark is kind of credited with 1896 that he came up with the comparative anatomy, and he described Insula as the fifth temporal lobe. Before that, Christian Riehl had named it. He looked at it, and it was named after his name as Island of Riehl. But as our talk would progress, we'll realize that Insula is anything but island. It has a very rich connections with the surrounding regions. So Insula, if you want to look at the Insula, you have to pair apart the Sylvian fissure to look at it, and that's, the pictures can give you an idea why it was called an island of Riehl. So to start with, I just want to spend a few minutes on the Sylvian fissure. Sylvian was a Dutch-German anatomist who, this Sylvian fissure is named after it. Sylvian fissure has two parts, the orbital part and the lateral part. And Sylvian point, I don't have a pointer, but the circular thing is Sylvian point, which kind of separates the orbital part from the lateral sulcus. The Sylvian fissure, as soon as it gets to the lateral surface of the temporal lobe, it is divided into three rami: the interior horizontal ramus, the vertical ramus, and the posterior ramus. And then it traverses back, and it's surrounded by, in the front, on the top, actually this picture would describe it, by the frontal opercula, the parietal opercula, and bottom by the superior temporal gyrus, which would be the temporal opercula. And this becomes important because there are some important vital parts, our eloquent region, which we have to be kind of considerate when we are thinking about the surgery in this region. So along the anterior horizontal ramus, there are three important regions which are kind of yellow, green, and red, and they are the pars orbitalis, pars triangularis, and then pars opercularis. Then there is a precentral and postcentral gyri, which are kind of purplish and reddish. And on the bottom line is the superior temporal gyrus, which is starting from the front to the back. In the middle is Heschel gyrus, and planum polaris in the front and planum temporalis in the back. So this is the blood supply of the insula and the Sylvian fissure. Basically, the arterial supply comes from the M2 branch of the middle cerebral artery. Venous supply is from the Sylvian fissure. and from the sylvian vein, as well as the middle cerebral vein, which drains the insula. I put these pictures on more, not to talk about the arterial supply, but just for a reminder to the people who deal with epilepsy, including me, the epileptologist, that when we ask for the 8 stereo EEG electrodes to be put in there, we have to keep in mind that somebody will need to thread this electrode through these arteries and veins, and there is a risk associated with, again, making the point about the over, and be cautious about the over and undersampling in this region. If we kind of prop open the sylvian fissure, the insula, it's kind of a triangular shape with the base directed downward, the tip directed downward, and the base on the top. And it is limited by the limiting sulcus in the surrounding region. Itself, it's divided into, by a central sulcus, into the anterior lobe and posterior lobe. Anterior lobe has 3 main gyra as the anterior, middle, and posterior, and there can be an accessory and transverse gyrus which can be present there. The posterior lobe has relatively long gyrus, the anterior long and posterior long, and H is for the facial gyrus. Where the anterior lobe comes together, that part is called apex, and where the long gyrus come together, that is Lyman insulae. And just medial to Lyman insulae is anterior perforating substance with the perforating arteries in it, and that's kind of an important anatomical landmark. So talking about the insular epilepsy, so I try to divide it into the 2 parts, the sign and symptomatology, which is associated with epilepsy or epileptic seizures, which are coming from purely from the insula. So I'm just going to spend a few minutes on this slide because I think it's important that when people, the problem with insula is it's not only hidden in the sylvian fissure, is similarly the symptomatology presented by the insular seizures can be very deceiving. So one thing I try to, these are the symptoms which should make an epileptologist think about that this is coming from insula specifically. So consciousness and contact with the environment is fully preserved. That's one factor which would, as compared to the temporal lobe, that will make you think that could be an insular seizure. Somatosensory auras, they are more likely to come from the posterior 3/4 of the insula, and could be sensation of tingling, warmth, electric current, or pain. Pain can be really should make you think about the insular epilepsy. And then viscerosensitive auras or paresthesias, they are more likely to come from the anterior insula. Sensation of choking, constriction, suffocation, seizing the neck sign. People would often hold their neck with their hand at the onset of the seizure. Clues to the earlier insular onset regarding those somatosensory or viscerosensitive symptoms. Often the paresthesias are plus, like they can be often associated with gustatory auras or olfactory auras. They often cover a large cutaneous area. They are not kind of a dermatomal as you would expect with primary sensory cortex or parietal seizures. They are often bilateral, and there is no Jacksonian marching with these sensory symptoms. They can be painful, and then there is often cervical laryngeal symptom. The seizure can be oral, mouth, and the throat. They can be mostly contralateral, but can be bilateral, and rarely can be ipsilateral, and often followed by auditory symptom and dysarthric speech. So, and then these are the primary symptoms which you expect that they would come from purely insular region. But of course, as I said, the insula has a rich connections with the surrounding areas as well. So before I go to those symptoms, I think it was alluded in the earlier talks, but I just want to spend a couple of minutes on this slide, that in 80s and 70s, we were doing a lot of subdural grids and maybe some depth electrodes. And the concept of epileptic focus model was very prominent. Lurie was kind of a leading person who published a lot about. He distributed the epilepsy regions into irritative zone to epileptogenic zone. Bottom line was they recommended that area the epileptogenic area is the one which you have to resect for complete seizure freedom. So that concept started to change with the stereo EEG electrode use. Spencer eloquently kind of talked about it. He said that the network as a whole is responsible for clinical and electrographic phenomena that we associated with human seizure. So they introduced the idea of that epilepsy is a network disease. You just cannot look at one area and think that the seizure, if you're looking at sign and symptomatology, you have to look at the whole network where the seizure started from and where the seizure went. And they recommended that the epileptogenic zone be named the initial organization of the seizure, not only that, but also early spread. If we think insula as a node of the onset of the seizure, and we talk about what symptoms you would expect, which would come from the insula, we already talked about that. But then, as I think we saw this slide as well before, that there is a rich connections of insula with the surrounding area. So if in your symptomatology, you are getting the patient has, if you do a video EEG and capture a typical seizure, if you see a tonic-clonic activity of the face, if there is a dysarthria, if there is a gustatory hallucinations, hypersalivation, or post-ictally patient has a facial paresis, then you would think, along with other symptoms, that you're probably insula worked as a node, but by this time your seizure has spread to the connection or the network is the temporosylvian insular network. And when the seizure spread to, and then if you are thinking about stereo EEG, then think about you will target the insula, but you should also be sampling the your perisylvian or superior operculum. And when the seizures are more kind of auditory hallucination, early aphasia, then you would think about that probably the seizure, your network also involves the infrasylvian opercular cortex, and that part should be sampled along with the insula as well. At the same time, if your patient has insular finding at the beginning, but then there are symptoms which you expect from typical temporal lobe seizures, like if they're staring, they are drooling, they have more automatism, then you would think that this is not only insula, but also the frontal pole and mesial temporal lobe structure involved with it, and that should be part of the sampling as well, because there is a strong reciprocal connection between anterior and inferior insula and the anterior pole and amygdala. If you see, I think there was some example of a hypermotor seizure. So that I think people should think about insular seizures if there is a hypermotor activity, but it's preceded by the more sign and symptoms of the initial insular involvement, or if there was a nocturnal seizures which have become diurnal, you should think about insula as a cause, because hypermotor or nocturnal hypermotor seizure can have an onset from the anterior superior insula. And then in the very young children, insular seizure can lead with spasm-like activity as well. Rarely you can see signs and symptoms of vertigo, feeling of unreality, or olfactogustatory symptoms. So I put this slide in. It's just a slide which shows how you can approach insular seizures with stereo EEG. But the only point I wanted to make, and I wanted to remember from this slide, was that I think it's important that when you sample insula and the surrounding network, it's important to sample both in orthogonal as well as in oblique, because they both type of approaches give you different kind of information. I just want to close with a case. How much time I have? 2 minutes. Okay. So this a 9-year-old had a hypermotor seizures, and he was seen in another institute. So over there, he underwent a workup. I think they had scouted the insula, but they were more focused on the frontal lobe because of his hyperactivity, and they had only used the oblique trajectories. And they found that the seizure onset was from the right frontal operculum. So ablation of the superior and anterior operculum and the insula was performed. That was not, his seizures got partially better. There was no MSI or MAC studies on this patient. So this patient came to our institute. We kind of fortunate enough that we have a big research institute, and they any patients who get a clinical MAG would also get electric source imaging, which is the high definition EEG, as well as the research and clinical MAG. So I'm doing the clinical MAG. So this is our research team. We recorded this patient. This is the high definition EEG recording with the interictal spikes on the left. Seizure, we were able to capture a typical seizure. That's on the right side, on my right-hand side. This is the research MAG, which was performed on him. Same thing, interictal activity, seizures. And this is the software I use for clinical MAG. And what we noticed that there was the ablation and the cavity was right there, but the MAG dipoles were present at the base of that cavity and the surrounding area in the anterior insula. So we planned this is the, again, the AMI data. This is a free software which we use. And this was our planning for the stereo EEG implantation. As you can look in the orthogonal, we had kind of completely surrounded the area of that previous surgery. And we were able to capture a lot of interictal and ictal activity. This is a kind of a surgical 3D map of that patient. We found a kind of very tight dipole cluster in the stereo EEG electrodes. AC is anterior cingulate. There is a frontoorbital at the bottom. So you can really demarcate the boundaries of that dipole discharge. And so we had to do an open resection of this patient. And I think that this patient benefited from kind of magnetic source imaging, as well as just putting the stereo EEG electrodes both orthogonally as well as with oblique approach. These slides are reminders that even when you do everything right and everything goes as planned, counseling of the patients is very, very important. And I think the role of the epileptologist as well as the epilepsy surgeon, these are all invasive procedures. When you decide to proceed with it, the counseling has to be done. There's always a risk of complication. So this is an early complication. I call it early, like still patient had the stereo EEG electrodes in. There can be complications like this is an intraparenchymal small hemorrhage. There can be a subdural hemorrhage, intraventricular hemorrhages. You can see it when everything, you have planned it perfectly and done everything right. So again, emphasizing being careful with the over and under sampling. This is a slide of a patient who, I call it a late, but this was 3 days kind of late intraventricular hemorrhage after the patient went home. So these all complications are a possibility. And I think when we do approach these patients with stereo EEG or any invasive procedure, you have to have a counseling with the family that what can be a problem. I'm done with my talk. I have actually a question, before I kind of hang up, is there any institute here where you guys do the stereo EEG and limit patients' air travel after the procedure? Air travel after that? No. We don't. Huge amount. Okay. Yeah, we don't either, but we just this year we ran into 3 times. There was one more slide I had put in there with the intraparenchymal hemorrhage. Actually, this was the patient, the one who had a small bleed in the insula. The patient flew after 2 days, and it really blew up. And we 4 days, yeah. Good. Okay. Thank you. Thank you very much.